Hello everybody, I am Dr. Amol Murkut. I am IPS of 2021 batch. Here we will today discuss about the medical science paper of 2021. Medical science test series. The test number is S533 and it contains subjects of medicine, pediatrics and dermatology. As we can see the important subjects of paper 2. So we will start with the question 1. It has a question. As we can see, UPSC is given at least 5 sub-questions to the question 1 and question 6, so that it can cover all the subtopics or all the subjects given in that paper, so that you cannot escape from preparing any subject. So you have to prepare all the subjects, and that's why they are giving the sub-questions. So according to that, here are 5 sub-questions of 10 marks in question 1. And in each question, it is also divided into subparts. So what happens here is, it becomes easy for you to answer the question and determine the length of question, because each subpart carries the given marks. So question 1, enumerate the causes of acute hepatitis. So what you have to do here, you have to first think about, say, you can see infectious causes. Sorry, it's not working very properly. So we'll close this thing. So you have to see infectious causes first, then drug-induced or toxin-induced second, then third is alcoholic, then fourth is non-alcoholic steatohepatitis. In infectious, there are viral causes, bacterial causes, or parasite. But most important, they are and most common is viral. And which viruses? Hepatitis viruses. Hepatitis A, hepatitis B, hepatitis C, D, and E. Then cytomegalovirus, Epstein-Barr virus, this can also cause hepatitis. Then few bacteria, sometimes intestinal infection of salmonella can go to the liver, and few other bacteria can also cause hepatitis, but it is rare. Then there is alcoholic hepatitis. We all know about that. Then there is non-alcoholic fatty steatohepatitis, fatty liver, and consequent hepatitis. Then there is drug or toxin-induced hepatitis. So these are the main causes. You have to write them. What I have seen in few papers is that people are writing extra causes of acute hepatitis, which don't exactly belong here. These are the 4 main categories, and if you write them, that's enough. Don't unnecessarily try to write one diagnosis in 2 forms. See, what you have to remember is, in UPSC questions, you have to understand the essence of question. If you are not fulfilling the demand of question, and you are trying to write like our college exams, university exams, then your marks will suffer. Okay, so be cautious about that. And second is, what are the clinical manifestations of hepatitis B? And describe the serological values in investigation of hepatitis B. So it carries 3 marks, just 3 marks, but question is quite big, है ना? तो इसमें हमें क्या करना है? Clinical manifestations. He hasn't asked about the acute hepatitis or chronic hepatitis, but we will understand here that, or we will assume here that he is asking about the acute clinical manifestations of hepatitis B. Or what you will write here? As you must have read, it is the acute hepatitis has prodromal phase, then icteric phase, then recovery phase. Then what happens in prodromal phase? There you have fever, chills, body ache, myalgia. Icteric phase, there is jaundice. In recovery phase, there is recovery and symptoms gradually subside, and appetite and appetite returns, and jaundice also subsides. All the clinical symptoms subside. So these are the acute manifestations. Then you can write one line about the chronic hepatitis B. You can write that it depends on the level of liver damage by the hepatitis B, and vague ill health. Vague ill health is one of the symptoms of chronic hepatitis B. Then serological values. What are the serological values in the investigation of hepatitis B? The important markers are, what are important markers? First is which are the antigens? HBsAg antigen, then HBe antigen, then HBV DNA. These are the main antigens. What are the antibodies? Anti-HBsAg, anti-HBeAg, anti-HBcAg, core anti against the core antigen, and there is HBV DNA. Sorry, it is not antibody. So these are the main antibodies. So you have to write up according to that. These are the antigens and these are the antibodies responsible for the investigation of hepatitis B. So you to recognize if it is active infection, then you will have HBe antigen and HBV DNA in your serum. And if there are antibodies against anti-HBeAg, so it means that your active replication or active multiplication of virus is not going on. So you can write that also, but it is just for 3 marks. So enumerating the test and just writing when you can write in early phase, then you can write when there is seroconversion, and that is enough. Then third question, how will you manage a patient with chronic hepatitis B? What are the antivirals used? In a few answer copies, there has been what you can see. People have written the symptoms of cirrhosis. Chronic hepatitis B and cirrhosis are different things. So in chronic hepatitis B, you don't have here. First of all, they haven't asked about the symptoms. So don't go down that path altogether. So what you will do, you will have what we can say symptomatic management. The first is you can say diet, supplements of vitamins, vitamin K if liver damage is more. So go along that path. Supplementary management, diet, supplementation of the nutrients such as vitamins, and then antiviral treatment. So what is antiviral treatment is mainstay of chronic hepatitis B, especially the when the hepatitis B is in active phase or there is acute exacerbation of the hepatitis B, chronic hepatitis B. So which are the antivirals used? First is the interferon alpha. Interferon alpha, what it will do? It prevents the viral replication. It brings down the viral levels. Then there is tenofovir, then lamivudine. So these also few more drugs are there. So these 3 to 4 at least you have to remember. Interferon alpha 2b. Then there is PEG interferon alpha, which is a pegylated form of the interferon alpha 2b. Then there is a tenofovir, lamivudine, and these drugs are these are the drugs which are used for the chronic hepatitis. Okay. So enumerate the various uses of CT scan. One 10-mark question is over here, and we have moved on to the question B, or we can call sub question B. Enumerate the various uses of CT scan. What is the principle behind it? Uses of CT scan क्या है? आपने जो भी you can say what you can say all the 3-4 investigations which we are going to see in medicine. We can say USG, CT scan, MRI, X-ray. So what you have to do? You have to classify these things into say we can say bone, then Another is, you can say, soft tissue. Bone, soft tissue. Then what is there? Malignancies. With bone, joints are also there. Then bone, joints, soft tissue, malignancy, body cavity. You can divide your investigations or the uses under these headings. So what is use of bone? CT scan in analysis of bone. Is it required in fracture analysis? Not exactly. But in case of tumors, CT scan is good. In case of joints, again CT scan is helpful to analyze the joint, any pathology in joint. Any. Then there is a soft tissue tumor. CT scan is very useful in that. Malignancy, then spread of malignancy. Then CT guided biopsies are there. So in all these things, in case of body cavity, it can see about the any pathology in say abdominal cavity, any fluid accumulation, or you can see the in case of stroke, you can analyze the brain with CT scan. So these are all these uses are sufficient. So what is the principle behind it? What is the principle behind it? It means CT scan uses the X-rays to generate the detailed 3D images of your interior of the body or the body organs. So that is just a simple principle. It's not very difficult to memorize. Then sub-question 2, describe the etiopathogenesis, clinical features and management of depression. What we can see, the etiopathogenesis is of depression is not quite understood. So what you can write? You can write about the we can see you can create say endogenous causes, exogenous causes, and you can combine them and write into etiopathogenesis. What are the endogenous causes? It can be multiple, say biological causes such as metabolic abnormalities, then there cerebral tumors or trauma. This can also cause depression. Then in exogenous causes, what are the causes? Or in endogenous, we can call the imbalance in our neurotransmitters, or the dopamine hypothesis is widely accepted these days. But few contentions are coming in medical fraternity regarding the dopamine hypothesis. Then there is exogenous causes. We have seen the endogenous, then there is exogenous. What are the exogenous? Life conditions, frustrations, tensions, unfavorable life incidences such as loss of loved one or the some life failures in career also. This can lead to the what we can say depression. Then these are the etiology, then there is a pathogenesis. All these things can cause imbalance in your neurotransmitters, or the deficiency or the hypoactivity of serotonin and dopamine. So, and because of that, there is a depressed mood, and we can call what we can call depression. So you have to write this in form of flowchart. Okay. So then there is a what we can see clinical features, the diagnostic features, which we all remember. What is the most characteristic symptom of depression? A persistently depressed mood. Okay. Then there is a loss of interest in everything. Then feeling of worthlessness, hopelessness. Then loss of interest in surrounding. There may be sleep and appetite may decrease, weight may decrease, and so these are the few clinical features. We all know the clinical features of depression. Then there is what is the management. So first you have to write about the pharmacological management. Okay, because pharmacological management is important. And what I have seen is people haven't given much importance to the pharmacological management and have just mentioned one drug, and just have written about the counseling and family support. See, counseling and family support is not everything in treatment of depression. Because whatever you say, the depressed person will take a negative meaning of it. So counseling is not, it is supplementary. It is not mainstay of treatment. Mainstay of treatment is pharmacological. So you have to write the pharmacological treatment. What are the drugs used? Atypical, tricyclic antidepressants. Then there are selective serotonin reuptake inhibitors. Then there are atypical antidepressants. So you have to write examples of at least 2 drugs of each class. Then there is a counseling, as we have mentioned earlier, and then there is what we can say behavioral therapy, counseling, family support. These are the things where we can work for the depressed patient. Okay. So again, moving to the sub questions. 8-month-old infant with TOF, tetralogy of Fallot, was brought onto the OP with excessive crying, dyspnea, bluish discoloration. What is the likely diagnosis? What are the other conditions that cause cyanotic spells? Okay. What is likely diagnosis? Likely diagnosis is your cyanotic spell. It is a plain and simple diagnosis. You don't have to scratch your mind to come arrive at the diagnosis. So cyanotic spell, because in next line he has given the cyanotic spell. So it is no brainer. Just what we can say, Foucault ke mark se Brownie point se. What are the other conditions that cause cyanotic spells? Simply you have to write about the other cyanotic heart diseases, nothing else. People are writing respiratory causes and whatnot. Why are you going in that direction? Just write about the other cyanotic heart spells. All the conditions with pulmonary stenosis, single ventricle physiology, or ischemization of the heart, or transposition of great arteries, VSD, PDA, and with pulmonary stenosis, with all single ventricle pathologies, physiological conditions. So just write the 3-4 conditions with cyanotic, congenital cyanotic heart diseases. That's enough. Okay. Then sub question: describe the pathophysiology of the condition. See, here few people have written the physiology or the hemodynamics in TOF. You haven't been asked that. You have been asked the pathophysiology of the cyanotic spell. See here, what I mean about the demand in the question in UPSC is this: you have to understand the demand of question. Describe the pathophysiology behind the condition. It means pathophysiology behind the cyanotic spells. Okay. Okay. So, what is the pathophysiology? There is a preceding events. Usually, the child may be crying, the child may be playing, and because of that, there is an increased demand or sympathetic stimulation is there. Because of sympathetic stimulation, there is constriction of the pulmonary outflow infundibula. Because of constriction of that outflow tract, there is a increased pressure in right ventricle, which passes from 2 VSD to the left ventricle. There is mixing of blood, and there is cyanosis, cyanotic spell is there. And simply because this is the simple pathophysiology of cyanotic spell. You have to write it in the form of what you can call a flow chart. Okay. What is the say we can say crying or playing. The child is crying or playing. Or if child is elder, he is playing. Or if he, as we can see, the 8-month-old infant, usually it starts with crying, fever, any physiological stress. Then there is a sympathetic stimulation. Okay, है ना? Sympathetic stimulation है, उससे क्या होगा? आपका आउटफ्लो ट्रैक्ट जो है वो डैमेज होगा. तो सॉरी, डैमेज नहीं होगा, कॉन्स्ट्रिक्ट होगा. तो कॉन्स्ट्रिक्ट होगा तो राइट टू लेफ्ट शंट होगा और साइनेप्टिक स्पेल हो जाएगा. सिंपल है. और पेरिफेरल रेजिस्टेंस भी डिक्रीज हो जाता है इस सिचुएशन में. सिंपल आपका पैथोफिजियोलॉजी है, वो लिखना है. Okay, then management of the child in the emergency room, है ना. मैनेजमेंट में क्या है, वो जो घई में टेबल दिया है, वो चार्ट जो है वो आप सबने याद रखना है या मेमोराइज करना है. व्हाई डू यू नीड टू मेमोराइज दैट चार्ट? Because cyanotic spell or all the any PITS question, it is a very repetitive question. Almost every year the cyanotic spell is asked, almost every year without gap. So you have to remember, if this question is highly probable question, then you have to remember that chart, the sequential treatment. What you will do when child comes, you will start, you will give knee chest position, then there is a start O2 supply, then give what you can call, we give beta blockers, then give the morphine to the child to sedate the child, then give correct the acidosis. Then if there is seizures, you can give what you call midazolam or diazepam. If the child doesn't respond, then vasopressors, or if also then also if child doesn't respond, in the end intubation and planning the corrective or surgery or temporary surgery, what we can say. So these are the thing. This is the treatment chart. You have to remember always. You have to memorize it. If you can remember the dosage of the drugs, say morphine 5 mg, then it's better because you will get more marks. This paper question is asked every year. Okay. Just 1 second. Okay. Where were we? Describe the long-term solution. What is the long-term solution of the top, or the we can say prevention of the cyanotic spells? You have to do the corrective surgery. Okay. When 28-week-old preterm baby had tachypnea immediately after birth, grunting, flaring of nostrils, and chest retraction. What is likely diagnosis? What are the other differential diagnoses? See, preterm and immediately after birth, respiratory distress syndrome. आग बंद करके एक ही डायग्नोसिस है. Or what do you do in writing? You have to write that likely diagnosis respiratory distress syndrome. Please write answer in that format so that the examiner doesn't have to search for your answer. Okay. Likely diagnosis, what you say, respiratory distress syndrome. And other differential diagnosis, again in GHI, after the chapter, what we can say, the respiratory distress syndrome, we can see about the respiratory. See, this is GHI. There is a, we can say the newborn infant, the chapter of newborn infant. See, here see, here I will bring closer to you. In here he has given box of the causes of respiratory distress, not respiratory distress syndrome. The respiratory distress, the conditions which can be differential diagnosis of the respiratory distress syndrome. What are those conditions? See, the cardiac condition, congestive heart failure, congenital heart disease. As we can see the cyanotic spells. then metabolic hypothermia, hypoglycemia, metabolic acidosis, then CNS causes asphyxia, hemorrhage, then chest wall, what can happen to your chest wall, trauma, asphyxia, है ना? So you have to remember this table, okay, of the grade. So this can be useful for you, okay. You have to write that as a differential diagnosis, okay. You can say pneumonia, but it wouldn't start immediately. It will take at least some time. Okay, then enumerate the investigations that are needed to confirm the diagnosis. See, most important investigation here is X-ray, which is where we will see ground glass opacities. Then second, we can do the arterial blood gas analysis to analyze the severity of the disease. These two tests are enough. Whenever you write the investigations in any clinical case, it may be PET, surgery, or medicine. What you have to do? We have to write the test which we do in clinical conditions first. Okay, you don't write everything which you know, or the test which may be done in research setting or for the very, what you can say, a rare case. You know, in clinically, all the physicians know this is respiratory distress syndrome. You don't have to go to the what do you say, very sophisticated investigation. Just one X-ray or ABG is enough. In clinical settings, sometimes that is also not done or that is not needed. So we have to write that first. What you will see, and also in all tests, you have to write what you will see there. Okay, don't just write the test, X-ray chest. But why? What you will see there, ground glass opacities. Okay, you have to write that. If you don't write that, then it's of no use. Then ABG. Few people are writing about the bronchoalveolar lavage and detecting the levels of the what we can say surfactants. But it is not usually done. You don't have time for that thing. You don't have setup for it. You don't have the investigative laboratories for that. Please don't write the things which are not done usually in clinical setup. Okay. Then you can write it, but you have to mention there rarely done or what you can say not usually done. ये आपको लिखना है वहां पे. That shows you have the clinical knowledge. That it shows that you haven't just read the theory. Okay. How will you manage the child? What are the preventive measures for this condition? How will you manage? First is O2 supplementation. O2 supplementation कैसा देना है? 100% O2 नहीं देना है because there will be retinopathy. Then most important treatment is divide the treatment in two aspects: supplementary treatment and definitive. In supplementary, what you have to do? You have to give O2. Then you have to maintain his metabolic, prevent the acidosis or correct the acidosis, maintain the blood glucose levels. These are the supplementary treatment: hydration, blood glucose levels, electrolyte balance, prevention of metabolic acidosis, respiratory acidosis, and correction of the respiratory acidosis. This is the supplementary treatment. In the definitive treatment, what you have to do? You have to do the you have to quick in and quick out of intubate out approach. Intubate the child, give surfactants through the intubated you can say tube, and just come out. It is most effective treatment. So then what are the preventive measures? In preventive measures, you have to give steroids to the mother. If the premature delivery is expected, then you have to give what you have to give. You have to give steroids to the mother before the delivery. Okay. Then we will move to the next question. Okay. Question E. है ना? A 12-year-old girl presented with complaints of milky white patches, skin around the lips and near the eyes. क्या है? स्किन का क्वेश्चन है ना? स्किन में क्या है? विटिलिगो का क्वेश्चन है ना? Sorry, it's not working properly. ये क्या है? स्किन और विटिलिगो का क्वेश्चन है. सिंपल क्वेश्चन है. What are the theories behind the pathophysiology of this condition? See, you haven't been asked pathophysiology. You have been asked theories behind this pathophysiology. Okay. So, but it is for 4 marks. So you have to explain a little bit, say in single line. What are the theories? There are 3 theories. One is what is autoimmune. That is most common. Then second is neurological. Third is genetic. Genetic means it goes to the autoimmune angle. But you have to write that. So understand what few people they have done. They have written the pathophysiology of the autoimmune hypothesis of the vitiligo. But you have to write the theories, all 3 theories. Okay, neuronal, then autoimmune, then genetic. Okay, then and explain these in one line. Then classify the disorder. How will you classify the disorder? Segmental vitiligo, generalized vitiligo, or vitiligo vulgaris. Then vitiligo generalized or vitiligo, which we call vitiligo vulgaris, it has subtypes such as acrofacial, lip tip, vitiligo. So in that format, you have to classify the disorder. Then line of treatment, side effects of the treatment. Most usually what we do, we give the topical treatment. What are the topical treatment drugs? Usually we use topical steroids and sometimes psoralen are also used. So, and if the lesion is extensive, then you can use oral drugs in along with the topical drugs. And side effects, localized we can say because of the steroid local atrophy. Then if you give the oral steroids, then side effects, all the side effects of the steroids, such as low immunity, then growth retardation. All these are the side effects of steroid treatment. Okay. So moving on to the next question. Question 2. What are the common malabsorption syndromes in adult? What are the common malabsorption syndromes? One is what we can call gluten allergy, which is called what we call celiac sprue or gluten allergy. Second is tropical malabsorption syndrome. These are the common ones asked in our exams. Then what others? We can say deficiency of pancreatic enzymes, then deficiency of bile from liver. So then atrophy, what we can say, damage to the intestinal villi. These are the common malabsorption syndromes. Enlist the investigations required for diagnosis. Celiac disease एक तो serology है, दूसरा है biopsy. Serology में क्या देखोगे आप? मोस्टली IgA एंटीबॉडी रहेगी. IgA क्यों रहेंगी? ये तो मतलब ओपन सीक्रेट है. सारा GIT जो है उसमें IgA सिक्रेटरी एंटीबॉडीज रहती है, तो वही IgA हमारे लिए काम की है. तो which antibodies you will search for? You will see there are various antibodies such as IgA anti-intumesial, IgA anti-intumesial antibody, and various IgA antibodies against your intestinal villi. So IgA anti-gliadin, IgA anti-endomysium. These are the various IgA antibodies you will search for in serology. Then what is the definitive diagnosis? Then it is what you say, biopsy and seeing the flattening of the villi. That is the most definitive diagnosis. Then How will you treat the patient with idiopathic tropical malabsorption syndrome? Again, supplementary treatment and definitive. Supplementary, you have to give supplementation of the all the vitamins, proteins, and micronutrients. If there is dehydration, you have to correct that also. Electrolyte abnormalities also you have to correct. And in definitive, you have to treat the patient with tetracyclines. I'm giving for around 4 to 8 weeks of tetracycline daily orally. Okay. So, what is our next question? Differentiate between marasmus and kwashiorkor. Again, in GAI, there is a different. There is a chart given for the differentiation of marasmus and kwashiorkor. What is marasmus? Marasmus is a energy malnutrition. Kwashiorkor is protein energy malnutrition. Then that is the basic difference. Then you can see the condition of child in marasmus. Then in condition of child in kwashiorkor. In marasmus, child is attentive, playful, or irritable. In kwashiorkor, the child is lethargic. Appearance of the child in kwashiorkor, it looks like a sugar baby. In marasmus, very thin baby, which has baggy pants, monkey faces, less hair. Baggy pants are seen over buttocks, monkey faces on face. In kwashiorkor, the baby looks like sugar baby, but hair may show flag sign. The skin is, if in kwashiorkor there is edema, in marasmus there is no edema. Neurological changes may have occurred in kwashiorkor, which are yet to be occurred in marasmus. So there are various differences in marasmus and kwashiorkor, and we can easily write them. What are the age-independent indices to assess malnutrition? See, age-independent indices. There are only few age-independent indices, and we can say only two indices are truly age-independent. One is your mid upper arm circumference, and the other is skin fold thickness over your triceps, which generally remain constant between 6 to 60 months. Matlab 6 months of your age to the 5 years of your age. Okay. So the Shakiri tape method or the Bengal method, these are all the variations, or we can say methods of the measuring the mid upper arm circumference. And the other is triceps skin fold thickness. Okay, these are only two age independent indices. And third is, how will you manage a case of severe acute malnutrition? SAM. Well, this should be LQ actually for 15 to 20 marks, but here you have been asked it for 5 marks. So what you will write? Stabilization phase, rehabilitation phase. What constitutes stabilization phase? Treat hypoglycemia, hypothermia, infection, all these things. And in case of rehabilitation, you have to give neurological symptoms, you have to continue the diet, and you have to monitor the child. Okay. And also correcting the micronutrient deficiency goes on to the long duration. Okay. Question C. A 34-year-old male presented with violaceous pruritic papules on the flexor aspects of the wrist and forearm. Discuss how will you arrive at diagnosis. See, we all know it is lichen planus. Plain and simple. Okay, it is lichen planus. How will you arrive at diagnosis? You will do the clinical analysis. Now, what you say? Analysis of the lesions, and you can have the biopsy of lesion. So the next question, elaborate the histopathological findings, draw a diagram to explain the findings. What are the histopathological findings? See, histopathological findings, these are very simple. What happens? There is thickening of the upper layer, there is a granular layer. See, in what we have to do for the skin, you have to read it from the post-graduation books. You cannot read it from our Matthew. Okay, we have to read skin and psychiatry. We have to read it from PG entrance books actually. Okay, then see here I can show you. There is a diagram, small diagram. Okay, here this diagram explains the histopathological changes. What are those? There is thickened granular layer. Then there is a degeneration of basal cells. Then Max Joseph's spaces are there. Then colloid bodies and dermoepithelial junction, dermoepidermal junction. Okay, so these are the histopathological findings. And diagram, you can draw the simple diagram, which very easy. It's very easy. Okay. How you will draw the diagram? It is see simple kind of like this. So these are the, see, this upper is thick. This upper layer is thickened granular layer. Then these are the these are the basal cell degenerations. Okay, these are the basal cell degenerations. Okay, then this is these are the colloid bodies. Okay, these are the colloid bodies. Okay, what are these colloid bodies? So this is the diagram. Then how will you treat the patient during pregnancy? See, you have to treat all these skin conditions. See, all the skin conditions is mostly which are in our syllabus, except for the scabies, all are autoimmune, autoimmune pathology. So what you have to do here in pregnancy, all the immunosuppressants, skin in see in all the skin treatments, there is a role of steroids and immunosuppressants. But both steroids and immunosuppressants are contraindicated in pregnancy. See, lichen planus is not a very serious disorder, especially if it is localized. So what you have to do, you have to give the topical drugs, and some antihistamines can be given orally or also topically to prevent the itching. What you have to remember during pregnancy, only topical drugs, especially topical steroids and immunosuppressants are contraindicated. But if you have to use, you can use only topical. You shouldn't and topical steroids, emollients, which maintain the hydration of the skin and decrease the irritation of the skin. These are the drugs which are used in pregnancy. Please remember these things. Several students have written methotrexate cyclosporine orally as in a treatment of pregnancy. They are strictly contraindicated. Please remember this thing. Simple various antibiotics are also contraindicated, and you are directly going to the cyclosporine and methotrexates. It shows that means we have to use the common sense of MBBS here. I'm sorry to say, but please remember that in any case in pregnancy, you shouldn't recommend immunosuppressants. How can you even think of writing such treatment? Okay. So not everybody is writing that, but few questions I have seen these things. Okay. Then question 3. What are the risk factors and predisposing factors involved in schizophrenia? See, again here also, does everybody know about the, what you can say, there is no any accepted theory for schizophrenia also, like in the case of what we have seen in the depression. There are various reasons given for schizophrenia. What are those? Again, you have to start from endogenous and exogenous causes. What are the exogenous causes? The stress of modern life. See, the anxiety about the career, uh, family conditions are not good. The example of marital schism and marital skew, parenting is bad, stress of loneliness, migration, problems of career, any life stress or mental stress, other psychiatric disorders. These are all risk factors. Then in endogenous cases, there may be metabolic anomalies, there may be tumor in your brain, what you can say, then there are genetic causes. So these are the risk factors and predisposing factors for schizophrenia. Okay. Okay. So how will you manage patient with schizophrenia? What are the indicators of good prognosis? How will you manage? See, in schizophrenia, there are psychiatric symptoms. So, there are various hypotheses of schizophrenia. The most accepted is dopamine hyperactivity and hypoactivity. There is a hyperactivity in mesolimbic pathway, and there is another pathway, sorry, I can't remember, mesolimbic pathway and other pathway. So there is hyperactivity at one place and there is hypoactivity at other place of dopamine. So you have to use the drugs. So how will you manage the patient of schizophrenia? You will use antipsychotics. You will use a typical antipsychotic. You will use typical antipsychotic. Then this is pharmacological. Then family support, good nutrition, management. These are also important factors. And one thing you have to write in, if you want to get good marks, you have to write that first episode should be treated adequately. It should be treated for around 2 years or 1.5 to 2 years. Why? Because the future course of schizophrenia and the future relapses and recurrences depends on the treatment of the first episode of the schizophrenia. Okay. What are the indicators of good prognosis? Indicators, there are various indicators, such as there are more positive symptoms than negative symptoms, the age of patient, or are there any catatonic symptoms to the patient, the severity of symptoms, then how long the first episode lasts, how good the first episode has been treated. So these are all indicators of good prognosis. A 30-year-old patient developed sore throat and skin rashes, following which he developed dark reddish brown urine, facial swelling, and increased protein in urine. See, in this question, several people have done mistake of identifying this question as nephrotic syndrome. Clear-cut post-streptococcal glomerulonephritis is there, and in glomerulonephritis, it is a nephritic syndrome, not nephrotic syndrome. Usually, and see, mild facial swelling and mild protein in urine, these are not signs of the nephrotic syndrome. Mild protein will be there in urine in nephritic syndrome, or in this case post-streptococcal glomerulonephritis. Okay. Okay. So that he has nephritic syndrome. Okay. Or acute glomerulonephritis. How will you investigate the patient? What are the electron microscopic findings? Investigate, what you will do? You will do urine analysis, or what we can say renal function test, which you read in pathology remaining renal function test. What are the constituents of those tests? A physical analysis of urine. Then there is a urine microscopy in physical color, volume, pH, viscosity, what you say, osmolarity of the urine. These are the things. Specific gravity, I mean to say. These are the things which you see in physical analysis. Then microscopy, then microscopy, what you will see in microscopy, RBC and protein. Then what you will see, blood urea analysis. These are the things for the analyzing the renal function test. Then what you will do, you will have to see for the evidence of streptococcal infection, previous in streptococcal infection. You have to see the titer of the antibodies of anti-streptolysin O, anti-DNSB, anti-hyaluronidase. These are the several antibodies against the streptococcus bacteria. Then there is what you can say, one more about culture of your throat swab. Then this pathogenesis you have to write in chat. There is molecular mimicry by the streptococcal antigens and between streptococcal antigens and our body's antigens, especially on glomerular basement membrane, cardiac tissue, joint tissue. The antigen, there is antigen mimicry. Second, there is antigen antibody deposition, and because of that, secondarily the immune system gets activated and there is glomerulonephritis. Okay. Lines of management of patient, what are the complications? Lines of management, mostly supportive treatment. Few people have gone directly to the steroids. We don't use steroid usually regularly or generally in post-streptococcal glomerulonephritis. It is not a nephrotic syndrome. You have to give supplementary management, maintenance of fluid, hydration, electrolyte balance. I'll not, you can use the diuretics sporadically as much as needed. Then adequate proteins and managed calories. These are the things which you will do for the management of the patient. You have to manage the hypertension by giving antihypertensive. You don't give steroids usually in this case. Okay. Complication. There are many complications. It can proceed to the renal failure. It can proceed to the uremia. Then complications of uremia such as uremic encephalopathy, myopathy, cardiomyopathy. Then excess what you can say, malignant hypertension. Then severe edema. These all can be complications of the what you say post-streptococcal glomerulonephritis. The next question is 55-year-old lady presented with 1 year duration of itchy erythematous scaly plaques over bilateral knee, elbows, and extensor areas. Erythematous scaly plaques. Scaly plaques means we can directly go to the psoriasis. Okay. Then what is the most likely diagnosis? What are the differential diagnosis? Most likely psoriasis. DD, you can say the atopic dermatitis allergy version, but she is having 1 year duration only, so we can't go to the that aspect. But we can say the what are the diagnosis, differential diagnosis of psoriasis. We can call it candidal intertrigo. We can call it atopic dermatitis flexural version of the adult version. Okay, so there are various differential diagnoses of psoriasis which you can write here. Elaborate the variants of psoriasis. What are the inverse psoriasis? Variants क्या है? Gutted psoriasis है, rheumatoid psoriasis है. These are the variants of psoriasis. Then there are variants of psoriasis according to the site of body, flexural psoriasis, extensor psoriasis. Okay. What is inverse psoriasis? Inverse psoriasis means flexural psoriasis. Okay. What is the histopathological finding? Add a note on POA. Histopathological finding, we all know. In histopathology, you will see everything. The thickening of the basal layer, then there is a tortuous capillaries, then there is infiltration of the what you can say, various immune cells. Okay. Add a note on POA therapy. POA means what? Soralins ultraviolet therapy. What you can get topical or oral soralins and then followed by exposure to ultraviolet light. What will happen in this case? It will prevent the basic pathology of the psoriasis, which is excess proliferation of the your skin. Skin cells. Okay. Question 4. An 8-month child presented with several episodes of low stools for the past 2 days. On examination, the child was lethargic, sunken eyes, and decreased skin turgor. What are the causes of acute diarrhea? Enumerate the pathogens involved. Causes of acute diarrhea: various bacterial and viral infections, or what you can say, parasite. In bacteria, E. coli, Salmonella, Shigella, Vibrio cholerae, several are there. Campylobacter. In viruses, rotaviruses, most important, then sometimes cytomegalovirus viruses are also there. Then in case of parasites, amoebic entamoeba histolytica, Giardia lamblia in parasite. These are various causes. How will you classify the condition of child? See, you have to write that classification chart given in GAI. Mild, moderate, severe. Mild, child is good. Means eyes sunken, not sunken, sunken, very sunken, or dry, moist, dry, very dry. Mouth, moist, dry, or very dry. Then how he does drinks the water normally, eagerly, or poorly. General condition: is he active, irritable, or lethargic? Here, lethargy. What is the symptoms given? The child is lethargic and he has sunken eyes. What does that mean? It means he has severe dehydration. Then there is skin turgor. Does it go back normally, slowly, or very slowly? Okay. Explain the line of management in first hour of admission. He has severe dehydration. He has to be given the IV fluids. What is the mechanism of this? If he is less than 12 months old, then the fluids 100 ml per kg in 6 hours. If he is more than 12 years or 12 months old, that is 1 year old, he has to be given 100 ml per kg in 3 hours. Okay. Enumerate the causes of meningitis. Then enumerate the causes of meningitis. Various causes: infectious, bacterial, viral, or parasite. Bacteria, all types of bacteria: Neisseria meningitis, Streptococcus pneumoniae, Haemophilus influenzae. Then there are fungus, Cryptococcus candida. Then there are virus, cytomegalovirus virus, Epstein-Barr virus, Japanese encephalitis virus, several viruses. Sometimes drug can also, in leukemia also there can be meningitis, or drugs can also cause symptoms of meningitis due to irritation. Clinical science: elaborate the lab investigation. Clinical science means what are the clinical science? Clinical science, mostly there is a neck rigidity. Then there is a photopia. There is what you can say, the patient cannot stand the exposure to the light, or we can say intensive light. Okay. And then what is there? Clinical, this comes projectile vomiting, headache. This come under the symptoms of the meningitis. The most important is the neck rigidity. There are various signs: Kernick signs, Brzezinski signs. Okay, these are the most important signs of the meningitis. Elaborate the lab investigation, serology, blood investigation, and in all the investigation, especially in medicine and surgery, you have to do the general investigation. and you have to do the specific investigation. जनरल में आप क्या करोगे, CBC करोगे, ब्लड शुगर वगैरह करोगे, है ना. And in case of this, you will do the, what you can say, CSF investigation. CSF, you will see them, is it a clear, turbid, number of leukocyte, concentration of glucose. These are the things which you will see. Then what are the complications associated with condition? Write briefly about recurrent meningitis. Complication क्या है? Complication most important आपको neurological complication लिखने हैं. Neurological complication में आपको क्या लिखना है? Neurological complications में mostly आपको लिखना है focal neurological deficits such as aphasia, then difficult, what you can say, cranial nerve palsy. Then there can be various types of paralysis such as hemiparesis or paraplegia or isolated paralysis of any, we can say focal paralysis of you can say hand. These are various focal neurological, or blindness. These are various focal neurological complications. These are most important. Then other is increased CSF pressure, then herniation of the brain. All these are the complications of conditions. Then there may be other systemic complications such as there may be imbalance of electrolytes. These are the various complications. Recurrent meningitis. Recurrent meningitis means repeated attacks of meningitis. Why it can occur? There are various causes. There may be some routes to breaks in your cranium, such as we have seen CSF rhinorrhea occurs in case of damage to the cranium. So in that case, infections can get access. Then you can have the middle ear infection or mastoiditis. Then can be repeated meningitis. Then immunocompromised individuals having AIDS or on diabetes or on immunosuppressants, they can also have recurrent meningitis. Then how will you differentiate Stevens-Johnson syndrome and toxic epidermal necrolysis? Simple, involvement of the body surface area less than 10% or more than 10%. Mortality of Stevens-Johnson syndrome very high. And if treatment is not given, then 70-80%. If treatment is given, then 30-40%. Elaborate the predisposing factors of severity. How will you grade the severity? Predisposing factors may be some autoimmune conditions, or there are various autoimmune diseases, and also intake of drug, which is most important. Intakes of which drugs? Say the ART therapy, then several anti-epileptic drugs, then few antibiotics such as class of sulfa drugs. These are the predisposing factors for Stevens-Johnson syndrome. How will you assess the severity of the disease? For severity, we have score 10 system of analysis, or grading the severity of Stevens-Johnson syndrome. Score 10. What you will see? Body surface area involved, then how much skin has been denuded, area of denuded skin, then metabolic complication, then other involving kind of predisposing condition, comorbidities. These are the various parameters of the score 10 system, which according to which we grade the age of the patient, we grade the severity of the disease. Okay.